Hey everybody, Dr.
Hey,
Rob Silverman here. I've got an esteemed colleague, one of the most well-researched, prolific chiropractors I know, clearly a leader in our field in research and implementation, Dr. Brandon Steele. Hey,
well,
Brandon.
thank you for that introduction. I hope I can somehow live up to that.
Oh, you will. And I just want everybody to know, as I listen to it, one, please feel free to ask any questions. We're here to extemporize on any information you may need. Number two, Dr. Steele is also the co-founder of Chiro Up. It's something that I use in my office. So if there's any practitioners listening, check it out. It has been a valuable resource to help explain to my patients specific conditions and also a knowledge and a base of information. They do a monthly blog. So I'm really happy you're able to get some time out of practice and doing your research and everything. Come join us. We wanted to talk about 3 facts about lumbar discs that impact clinical outcomes. So let's dig right in. Let's talk. What's a disc? So many of my patients ask me, is it slipped? Is it herniated? Is it bulging? What is it?
Yeah, I'm always curious on that because you always hear about slip discs or rotary cup problems, and you hear those slang terms, and it's like, where do they get these terms from? Clearly we can't have a disc that has gone somewhere or slipped out of its spot. So to keep things kind of on task, I like to think of the disc as fluid, but not necessarily in the fluid that most people are thinking about. So one, the inside technically is a fluid, and it will have the same kind of mechanics that normal fluids have. However, the cool part about a disc that I think is pretty neat is that it's literally fluid. It changes. It changes based on injury. It changes based on metabolic health. It changes based on your sports that you play and your age. So those are things that I think that are kind of neat because the disc, when it starts off, is very fluid. And then it kind of turns into toothpaste, and then it turns into crab meat as we do more and more damage to it. And there's not one thing. I get those patients who say, how did I do this? Well, there was a paper that came out, Tuari, I think it was in the Journal of Orthopedic Science last month, that said it can happen anyway. It can happen from arthritis in the facet joints first, or it can happen in the disc problem first, but it all kind of ends up the same. It ends up in degenerative changes in the spine. So we probably stop chasing where it comes from and really focus on how did it happen, what's exacerbating symptoms, and how can we solve that problem and meet the patient where they are now.
Well, you just said it was a liquid, fluid.
The
Interesting. Right. In school, as we go back years and years ago, they said it was like a jelly donut.
Yeah, you know what? Let me expand on that because this is one thing that I didn't learn in school. And the disc can change its stiffness based on how you load it. So I think it was Nachmanson in 1970 said that when you sit, you put probably the most pressure on a disc. When you go to stand up, you put a little less pressure on the disc because you can share the load between the disc and the back parts of the spine, the facet joints. When you lay down on your side, you put a little less pressure. And if you lay on your back, you put even less pressure. So if you want to put the least amount of pressure on a disc, lay on your back. However, that's a static posture. That's not how people live. We don't just lay around, and we don't just, well, some of us do sit around a lot. So we do load the disc in that way. However, the thing that I think is so interesting about the disc is it can change its stiffness based on how you load it. Let me think about this. So I have a 6-year-old, and I just stepped on some Legos earlier because he likes to not put those away. Imagine a 5-gallon bucket, half full of Legos, and then you fill it up to the top with water after it's already full with Legos. If you slowly put your hand into that bucket, you can actually migrate through those Legos and probably hit the bottom of the bucket because it's fluid and the Legos are in there, but you can still get your hand through there. And that's kind of how the disc is, because the disc has proteoglycans and all these different molecules in it, kind of like Legos. And if you move slowly, then it just moves like a fluid. However, if you took your foot and pounced down on that bucket as hard as possible, you're going to say a curse word because those Legos are not going to move fast enough and your foot's going to hit it. So the disc is a non-Newtonian fluid. If you look at non-Newtonian fluid, just YouTube cornstarch, non-Newtonian cornstarch, and you can see how you can take cornstarch and you can move it around and migrate around, or you take a fork and you hit it as hard as possible, and the cornstarch doesn't move. So what I think is so neat about that study, that was Newell, I think, that found that study in 2019, is that based on what your patients do determines how that tissue responds. So if you fall on your butt and you load it really quickly, it turns hard as a rock. Guess what's something else is gonna break, not the disc, it's gonna shoot through the vertebral end plate, or it's gonna cause a problem somewhere else. If you are you're slow, you're picking up sandbags, constantly flexing and moving, that's a slow repetitive motion. Now you're gonna get something like an annular tear. So we need to stop looking at the actual diagnosis, because if you look at the orthopedic diagnosis, it doesn't really tell me what to do. It just kind of tells me what the patient's been doing and how can I affect their care. What have they done to themselves? And that's the neat part about this, because they just it provides a little bit of a window into what that person's been doing throughout their normal daily life. And those are the fun things as a manual therapist that we get to correct. We get to work with their sleeping posture. We can work with how they bend over or how they swing a golf club.
Fabulous. So I'm going to use my OK sign here. And the center part right in here, I guess I should do. That's the nucleus.
Yes.
And then this out part, that's the annulus. So this part we've always called gelatinous. And we realize that it's more liquid, but you're adding greatly that the viscosity and the tertiary of it changes depending on the movement and the load. Now, you can damage your nucleus and nobody knows till you get to the outer third of the annulus, because that's where the nerves are.
Mm-hmm.
So everybody always worries about, the cause, what did I do? So how do you get this out here? So what are the causes of a disc lesion, like a bulge and a herniation, if you could explain that?
Oh man, there's so many causes. And that's the crazy part, is that to do damage to the outside annulus does take usually rotation and flexion. That's our bending forward, or static flexion, like we're both doing right now, sitting for long periods of time. So that's how you're going to slowly load the nucleus. It's going to slowly push backward and now put stress on the outside part of that, that part of the ligaments, which is the annulus. And eventually that fluid, if you put enough pressure on it and it stays there for long enough, it's going to worm its way through that annulus, and it's going to find the outside, which is, in your spinal cord. And your body doesn't like that tissue. It's never seen that tissue before. And that's when we get that massive inflammatory reaction and pain that we would call a disc herniation. Now, one other way that you can actually injure that nucleus and not have it go through the annulus is for it to go upward or downward. And we call those a compression fracture, or maybe a small one would be a Schmerl's node. And that's when someone actually takes that nucleus and puts it through the bone, or the cartilage that separates the bone at the vertebra. So that's when someone falls on their butt or squatting a distance or a big load, and they can actually get that fluid and push upward. But the simple fact is that when you do damage and you have arthritis, that disc can no longer get nutrition, and that disc can't get the bad stuff out, the waste, and it can't get good stuff in, which is the nutrition. That's when it starts to degenerate. And what I tell my patients is that a normal disc, if you have a bone on top of a bone, it should just move along an instantaneous center of rotation. It should be, nice and normal. But when there's degeneration, you get sliding, you get translation. And my patients, and I'm sure your patients, describe that as a uncomfortable feeling, a sliding, a clunking, a grinding. And that's that sliding motion they're feeling. I mean, we call it as a sloppy part of their spine. And that's when we can, help that with stabilization exercises and work with their posture. Did that answer your question there?
Yeah, it does. So I'm going to play patient. I'll let you play doc.
Awesome.
Hey, doc. And by the way, for everybody watching, I see a lot of people tuning in. You're captivating the audience. If you've got a disc injury, but you don't know what it is, put D. If you've got a bulging disc, put B. And if you've got a herniated disc, put H. Just let us know. So I'm going to say D because I have disc damage. And it depends on who I ask. Are they herniated, if they're bulging and everything? But I use those terms. What's in your mind the best way to describe to a patient the difference between a bulge and a herniation?
Kind of back what I would talk about before is that just describes how you injured it. Unfortunately, whenever you lose disc material, whether it goes out the side, the annulus, or up through the top, through the vertebra, it causes the same problem. So a lot of times as a practitioner, we get confused because we don't know which way it's going. Because unfortunately, if you lose disc material and those two bones get closer to each other and that annulus bows backward, a disc bulge, it causes pain. It causes muscular spasm. It causes nerves to be compressed. So when we hear symptoms, we need to somehow differentiate where is it coming from? Because sometimes there's a treatment for a disc bulge that's different than a disc herniation or a Schmorl's node. So 2/3 of disc herniations are disc problems or herniations. 1/3 is actually a Schmorl's node when it goes up through the top. It's really our job to figure that out because that's where the magic happens. So many chiropractors and manual medicine and physical therapists, we're all timed. So we have to get our job done pretty fast. And we always try to find ways to speed up our treatment. However, in these kind of situations, if you can find a way to speed up your evaluation and do only the best test, then you can help yourself go a little faster, but also help the patient because you're not leading them down the wrong path. So for example, the heel drop test. So you stand up nice and tall, you're nice and neutral, and you go up on your forefoot and drop down on your heels. Well, you're actually loading your spine. Well, if you have a compression fracture, that's not going to be very friendly. Now we can say he's got a compression fracture. I can give them the right set of exercises and braces and the right prognosis. However, if you have a disc herniation, you can actually do a heel drop and not have any pain at all because the facet joints are sharing that load. You're not going to load that disc, that weakness in that annulus enough. So here's what you can do. Do the heel drop like you're supposed to do with the patient standing up tall, but now do the heel drop test when they bend forward. And if they bend forward and drop down their heels and they have a disc problem going through the back of the annulus, they're not going to like you very much. In fact, duck because it's going to hurt. But it's a good way to figure out which area you're dealing with. And those are the kind of the things that I think when you can marry sometimes we have an MRI on a patient, but when you can marry the MRI or the imaging, the evaluation, and then also the history and all things make sense, then we know exactly what to do with that patient. So it all starts with the evaluation and figure out where the insult is.
Well, in your evaluation, because I know you do an extensive evaluation, why don't you give us 3 tests or 3 functional orthopedic tests that you would use that you'd recommend all docs out there use in their evaluation?
Sure. So if I'm thinking about a compression fracture, which is 80% of back pain, I mean, 80% of patients over, I think, the age of 60 have an unnoticed osteoporotic vertebral compression fracture. So they're bigger than you think. In fact, there's more osteoporotic compression fractures than hip fractures, and people just don't realize it because we're not looking for it. So supine sign, so those patients are unable to lay on their back. So if a patient tells you, you ask them to lay on their back and they can't, that's a compression fracture until ruled otherwise. That along with the back pain inducing test, which is essentially just making the patient lay on their back, roll over, and then sit up. So finding different ways to load the back. But if those 2 things are positive, I'm thinking a compression fracture. When it comes to a disc problem, and I'm thinking a disc problem as far as an annular issue, you really can't aggravate those unless you have symptoms, meaning most of our patients that have disc problems, most everybody has a disc problem when you hit a certain age. So you're not going to find one of those on an asymptomatic person. What you are going to find on a disc person is when it's a disc problem that actually causes nerve symptoms. And those are the things that I'm going to look at more in my SLR or an extended straight leg raise. I did a blog on that about a month ago, and that is normally we do a straight leg raise and we do braggarts on the end of that. So we're looking for nerve tension. Well, if you have compression of any part of the lower leg past the knee and you do braggarts, well, technically you're tensing those areas also. So the extended straight leg raise is nice because you do a straight leg raise, but then instead of doing braggarts, you internally rotate the hip and also still stretch the sciatic nerve, irritating symptoms. So if you haven't seen that test, I really like that one a lot. As far as a disc problem, along with I think the main things that we hear when you have a disc problem is the mechanical stuff that I just talked about, but also listen for chemical issues because that's the stuff that really kind of bites us in the butt sometimes. If someone has pain that started a day after their injury, if it's a low-grade pain, if it's a constant pain, it's worse in the morning type of pain, then yes, you can still have your mechanical problems, but their pain is probably chemical. You need to solve that with a chemical solution, whether it's supplement, whether it's medication, whether it's whatever it is that you practice. You can't fix a chemical problem with a mechanical solution, just like you can't fix a mechanical problem with a chemical solution.
Just got a question in. They hit me on my phone as always. They want to know, somebody comes in and you want to take a diagnostic test. Do you order blood tests, x-rays, MRI? And if you do any of them, which one and what are you looking for?
For a disc type of patient, a low back pain.
Yeah, disc type patient. Someone you feel they have a disc injury and you want to get a diagnostic proof.
I work within a practice. However, I work with 2 medical physician groups. So I have a limited role as far as getting people out of pain as fast as possible. And one other thing that I think I do pretty well is I work well within a fence, meaning I have a very specific role. And then when patients fall out of my role, I have a very quick way of getting them into someone else's care. So as far as me, and this is my personal opinion, doesn't mean that's what every chiropractor has to do, but if I'm anticipating that a diagnostic procedure, like an injection or a surgery is going to help this patient, that's when I'm going to do an MRI. As far as for these kind of patients, obviously, if they have red flags, progressive neurologic deficit, any other of the red flags, those need imaging also. But in the absence of red flags, I'm just looking for, would an injection help this person? Because if they have a chemical component, a Medrol dose pack, a steroid injection, like it or not, is going to help that patient. So we have to play well within the fence, say, hey, I'm going to work this mechanically, but I could use some help chemically or with an intervention. And in that case, if I think like diabetes and disc problems are like peanut butter and jelly. So, if I think there's something else at play that I need another test for, that's what I'm going to order it. I'm not going to order a test just to appease the patient that, oh yeah, you do have a disc problem at L5, because at the age of 60, so does everybody else. We need to make sure there's a reason we're ordering that test to continue their care or improve their care.
Absolutely. So what's your prognosis for a patient suffering from discogenic pain?
We just take them out back and shoot them.
I think that's very effective.
Yeah. Disc patients kind of have a tattoo on their forehead that they tell everybody about their disc problem and their grandson. They can't do this and they can't do that. So I try to peacefully strip that label away from them and try to just educate them, not confront them, but to say, listen, I mean, the Global Spine Journal said, I think it was 2 years ago, 97% of disc problems were resolved just by themselves. They don't need any kind of care. And the majority of disc herniations will self-resolve. And in fact, the bigger that disc herniation is, the bigger the inflammatory reaction it causes in your body, and the faster it goes away. So it's the small little disc herniations that give us the most trouble. So, the size of the disc herniation has a negative predictive value on how they're going to respond or whether they need surgery or not. So from an image, I'm not going to really give them any kind of a prognosis. Now, if I do see a progressive neurologic deficit, or if I do see they're not getting anywhere after 2 to 3 weeks, not that they need to be resolved, but if they're not getting anywhere and they're having continuation of radiation of symptoms, then I'm going to call in, a friend as far as a surgery or a pain management doctor. But I'm positive. I'm probably the most positive person that you'll ever meet. It doesn't matter if it's walking around the block or treating a patient. I see the good in everything. So fortunately with disc problems is we're not usually proven wrong, is they respond really well to conservative measures like directional therapy, like manipulation. Those are the things that patients need, not the expensive things or things that have additive side effects, like certain types of medications or procedures.
Right. I was going to dig you kind of like you gave it to me. I was piggybacking into what treatments do you like best? So spinal manipulation is a big thumbs up for you. Directional therapy, traction. Let me know what you think. I got a text. They're looking for specifics. I know you got to give generalities versus specific to the individual patient.
Yeah, I am a chiropractor at heart, and I get more excited than my patients when I manipulate them. I mean, I honestly just love spinal manipulation, and fortunately, the research backs up my fascination with spinal manipulation. So it's the safest, most effective option. Now, when it comes to directional therapy, I do like directional therapy. I think it's a good graded approach, meaning if a patient can tolerate manipulation, I'm just going to go ahead and run through end range manipulation. But if they can't, and some people are hot or acute, that's when I'm going to use, more of a directional therapy evaluation and treatment as far as taking them through the progressions, supine to prone to standing with overpressure. So I do think that as a chiropractor, we can't dig our head in the sand and say, I'm only going to do manipulation. You got to have a bunch of tools in your toolbox. And directional therapy works well. Manual therapy, as far as just tissue stripping. I'm not a supplement person. It has nothing to do with me not seeing the importance in it. It's that I have a functional medicine person down the street. She's awesome. She's better. She's smarter. She's more likable than I am. My patients love her. So I send all those people that I think have that issue over to her, and she can take care of that variable when it comes to their pain. Traction is good. Unfortunately, a lot of people will be kind of acute and not do very well with traction, at least at the very beginning. And I love those teeters, those inversion tables you can buy at home. Unfortunately, a lot of people hurt themselves on them because they quickly, that fast rate of unloading, not loading, we're talking about the disc, that fast rate of unloading by going inversion causes more symptoms in those patients. So I try to stay away from at-home things that could possibly injure someone. But I'll tell you what, the best treatment for a disc problem is having your patient understand their condition just as well as you do. At the very beginning of this podcast, you said that I'm heavy into research. And while I think that's true, it's not so much me doing research. It's knowledge translation. It's looking at research and how do those things affect us, affect me in practice, and affect my patient. And what I found in practice is that if I can just relay everything that I know about their condition, what caused it, what's going to aggravate it, what's going to help loosen it up, what's going to help protect it, then the patient's going to find those variables in their life, whether the way they get out of bed, that stretch they've done for the last 10 years, the way they do their workout routine every morning. They're going to piece together much more and much faster what they did to cause it, much faster than I am. And if you can have that buy-in from your patient and you can provide them with the resources on how to sleep better, what 3 exercises are going to help get them out of pain, which treatments are the best, like manipulation and traction and directional therapy. When you can provide that recipe to each and every patient, that's evidence-based care. That's evidence-informed care that works. That's why we're the most effective and efficient clinicians in the world, because we care about our patients, we educate our patients, and we provide what they need.
With your Chiro Up, and I use it every day because you've got exercises, rehab exercises, lumbar exercises. So I know rehab is something that you believe strongly in, and the exercises that you have to choose from, there's a plethora of them. So I do recommend to all the practitioners and anybody to take a look at Chiro Up, look at those exercise rehab. Also, you're being very kind. You have a fabulous video where it talks about a disc and the anatomy of the disc and how liquid it is and everything. And I use it every day. I happen to have a computer in all my offices in every room. And I show them when people come in, because the model that we have, I should have brought it in the room, is pretty hard. If I hit myself in the head, I might give myself a concussion, and it does not mimic the texture. But that video, if you could talk a little bit about it, I'm sure some people would be interested in procuring that.
I don't have the link on, but if you go to chiroup.com and just go to our blog, you don't have to be a subscriber. The blog is just informational. So back to the knowledge translation, the blog is the new information coming into Chiro Up. And then what we do with Chiro Up is we take those new tests, those new treatments, that new patient education video, and now we make it available. So when a patient has a disc problem, you don't have to remember all the 7 things you need to know about a disc problem, or what are the 3 tests for tarsal tunnel syndrome, or what are the best exercises for rotator cuff syndrome. That's what Chiro Up does. It remembers all those things. So now you can just have to recognize it, which is a hard job. That's part of the most difficult things we have to do, is to do the proper evaluation. But as far as the treatment aspect of it and the knowledge translation aspect, we solve that. So we're not an exercise program. We're not a Google review service. We're not a MD marketing program. We just do all that for you once you make the right diagnosis. But go to that blog, Dr. Bertelsmann, if I have a couple minutes to talk about this, because it's really a funny story. he sent one of our staff members to the butcher, just a local butcher, and he called the butcher ahead of time and said, I just want one spine segment of a young pig because we're going to do this video, so we're going to dissect it. So Beth comes back and it was 2 feet by 1 foot block of a pig. I mean, it was heavy. So we had to dissect the whole thing out and then get down to the bone and then slice it. And it's really interesting because now this is a young pig, and remember, they don't walk upright. They are quadrupeds, so it's not the exact model of a human. But we didn't have any volunteers for people that want to donate a vertebrae to us. So it's neat because you get to see it. You get to see that consistency of the disc. One other thing is I have no financial interest, or I'm not an affiliate or anything, but Dynamic Disc Designs. Dr. Fryer, his stuff is legit. That those little models, I don't know how much they are. They're probably $300 to $400, but that saves me $300 to $400 each time that I have to explain to a patient how a disc works. I just bring the model out. Here's exactly what it looks like. Here's what a disc herniation looks like. Check out his site. Those things will save you time. I know I use them on a daily basis.
I've got them in my office too. I think they're stellar, without question.
Mm-hmm.
Now, you do a lot of traveling because I get to see you in all the different places, and it's always a pleasure, and we catch up and everything like that, and we work on our jokes and all that. But where are you going to be seen in the next month or two?
I go to Canton, Ohio tomorrow for Northern Ohio, the group. And then I'm going to Wisconsin after that.
See you there.
I'll be at Parker and Ohio again in the same weekend in October. One's Friday, one's Saturday. And then I'll be in Pro Sport in Vegas. So that's always a fun event. I never knew about Pro Sport when I was in school, but they do a pretty good job. I'll be at Maine, and I think I'm missing one. But yeah, I try to make my rounds and visit as many places as possible.
And how can you get in touch? Yep. Sorry.
It's always good to see people like yourself, Rob, because people come up and talk to us like they know us really well, and because we're constantly doing videos, and it's so funny because when I get to meet people like yourself, then we get to just kind of share experiences. So I really appreciate you having me on this. That we get to talk to your viewership, and I know we're going to post this on our social site. But also just, having a friend in the profession has just been wonderful, especially when you're moving towards the right mission, having, elevating, uniting the evidence-based chiropractic crowd. I just appreciate everything that you do in practice when you're on the road and also with this podcast. So thank you very much.
I really appreciate that. Thanks so much. It's always a pleasure. If someone's interested, how can they get in touch with you?
Brandon, BRANDON at chiroup.com, CHIROUP.com. And I'm a practicing doctor, so I work in clinic. So if it's a clinical question, give me 24 hours. I'll get the answer to you. If it's something else, I've got a pretty large network of people that if I don't have the answer, I will get back to you, and I'll get you in contact with someone who knows the answer to your question. I'm pretty decent clinically and with using ChiroUp, but if it's something else, then I might need a little bit of help.
Well, I'm going to give you a little plug. I think everybody should use ChiroUp. Got a question for you. Eric. Thanks, Rob. Just wondering how Dr. Steele feels about spinal fusions and its success rate with multi-level issues. Let me pop that up for you.
I'll kind of go back to, I think we talked about it earlier, is that if someone has, progressive neurologic deficit, nerves are a little higher on the hierarchy than your spine. So bones, ligaments, discs. So unfortunately, if you have nerve compression that's not going away, that requires, some invasive therapy, it is what it is. So I don't know if there's really even a thought process with that one. However, when it comes to disc problems, I see a lot more spine surgeons going for the non-invasive, they call it minimally invasive, but it's still fairly invasive, discectomies and those kind of things. The mild procedure, which is a minimally invasive lumbar decompression, which is essentially shaving off the ligamentum flavum, is once again, minimally invasive. It sounds pretty invasive to me. But those are the kind of things that they can do that can possibly help. And a lot of times it does help. It makes that spinal canal diameter a little bigger. So I'll always go towards, even if I have, severe symptoms, towards the minimally invasive type options, or I work with a pain management doctor that I can text on the phone and get someone in right away. And if you have mechanical obstruction of a nerve, then we need to work at it mechanically. However, if that nerve is mechanically obstructed and has ischemia and has inflammation, then the injection could possibly help and be a window of opportunity. So by no means am I sending anyone to surgery. I hope no one to surgery. But in those cases, you gotta realize your role and now protecting that leg if there's nerve compression and possibly even a multi-level fusion. I'd hate to have anybody do that, but sometimes it's necessary.
Yeah, it's a great option to have. It's just one you never want to have to utilize.
No.
I'd love to get you back on. And I think next time we get on, I already know what we want to talk about. I got a few people asking me. Cervical spine injuries, neck, and probably postural induced. So put that on your wish list. We'll get Dr. Steele back. It's been my pleasure. Like I said, Dr. Brandon Steele, Chiro up. He's a gem. Dr. Rob Silverman, always yours in health.
Thank you.